Tata Memorial Hospital. Starting from the first registry of hereditary cancer in the country, he developed a model cancer genetics unit comprising of a cancer genetics clinic and a genetics lab. He is the executive editor of the Journal of Cancer Research and Therapeutics, which is the leading indexed cancer journal from developing world. Sir will be talking to us about inherited cancers and risk management in women. Professor Rajiv Sarin.
Good afternoon, and thank you for inviting me for this meeting. And as we're talking of women's health, women's cancer, I'll be dealing with a different aspect of it, which is the inherited risk for cancer in women. And I'll be sharing with you my experiences gained by running a large cancer genetics clinic as well as a lab. What are the issues that we deal with in this? Next, please. Can I change my slides? Can I change my slides? Something to... Okay, so this is there a pointer or something? No, okay. This is, sorry, go back please. So this is a large family tree, what you call a pedigree of people in this family. You would see that those who have the blue shades, they had breast cancer and ovarian cancer, and a lot of people have also died in this family of cancer. So this was the lady with the arrow, that's the index case or the proban. This is the first family whom I sort of got introduced to as cancer genetics. When I was a resident doctor, I treated for her breast cancer. That time we were focusing only which chemotherapy to give, CMF chemotherapy or what kind of breast conservation and all those things. But later on, when I joined as a consultant, then she came back to me with contralateral breast cancer on the opposite side, and later on her daughter developed breast cancer. So this is a classical hereditary breast ovarian cancer family, but many times the way our hospital works and the way we take history, we miss such important family history. So South Asia, we are 1.6 billion people in this subcontinent. Basically, geography decides the gene pool, and we have more than 1.3 million new cancer cases per year. And if we take a very conservative estimate of just 2 to 5% of all cancers being hereditary, which is they run in the family because of mutation in certain genes, tumor suppressor genes, mostly like BRCA1, 2, P53, then we have close to 50,000 familial cancer cases in India itself. And if we take 4 members per family, we have 200,000 patients who need, or people, they are not necessarily patients, who require specialized genetic counseling, testing, surveillance, and now sometimes specific targeted therapy to derive the benefit of all the wonderful research that the world has done in the last 20 or 30 years. But unfortunately, how many comprehensive cancer genetics unit we have? Unfortunately, we do not have a single comprehensive cancer genetics unit to serve 1.6 billion people. Ours is perhaps closest to being a comprehensive cancer genetics unit, but the risk management aspect, the reconstructive surgery, the taking them through all those things are also not that well developed, or we don't have the outcome measures for that. So this is really the need, and this is very important, that anything that you do not do, any part of the service, if it is not comprehensive, you may not be doing good for these people, you may be actually sometimes harming them. There's no point doing only testing if you have not counseled them. If you have done the testing, then also you have to take them through the risk. If you cannot manage the risk, the physical, emotional, psychosocial, all aspects have to be taken care of. So this, in the last 10 years, previously we used to see very few patients, but when we set up a lab, I set up my lab also in 2007 and 8, we got extramural funding. Presently, this slide doesn't show up to 2015. Every day we get 3 or 4 new families with hereditary cancers. So the numbers for last year's was 700 new families were registered with various kinds of hereditary cancers. And more important, people who come back for follow-up, who come back asking for the genetic test results, for the risk management, for the counseling and surveillance. That is very important, because this indicates that these people see some value in the service, and ours is perhaps the only service in Tata Hospital in the country. Now, it used to be my lunchtime clinic. some 10, 15 years ago. About 10 years ago, I managed to get one part-time genetic counselor. And then we had, two part-time genetic counselors. Today we have 3 full-time genetic counselors, and they don't get time even for the lunch. So they're so busy, and each family takes a lot of time because each, on an average, 4 or 5 members per family. So the challenges for South Asia is that there are very few South Asian families are in the databases. The mutation spectrum is not really known, and there's a high chance of, if we do genetic testing for South Asians, because the database is so small, that we end up finding a variant of unknown clinical significance, and that becomes a challenge. Sorry, it's not working. And of course, we all know that the unique Indian psychosocial and family setting. So this really is a big challenge. This lady, everyone knows, she's Angelina Jolie. Of course, she's famous. Of course, she was always famous, but she became even more famous when she told her story that her mother, her aunt, and her grandmother all had cancer, hereditary cancer, and she carried this BRCA1 mutation. I called her inheritance of maladies and the gene fairy, because she brought attention to a condition which was not really so rare, but it was an orphan condition. There was no one really attention paid to this condition. And so there are more than 10,000 Indian women who have BRCA1 mutation like her, but what really goes through their mind and body, there's little data on that. So we did a little survey of our about 120 mother-daughter pairs who with us, and what we found, most of it was not surprising. 3 out of 4 had the guilt of passing on the risk to the daughter, the mothers who had hereditary cancers. 2 out of 3 had concerns related to their daughter's marriage in future, and 1 out of 3 was certain that her daughter would develop cancer. What was surprising, that 1 out of 3 mothers had not disclosed this, her own cancer diagnosis, amongst relatives and friends, mainly because they feared the social stigma and the problem that would create for the daughter in future. So this is, of course, now in retrospect, we know this probably makes sense, but it was an unexpected finding. So this is one of the family. Why I'm showing this family, sometimes when you look at the serials or some movies, you say all Indian family, there's one big stereotype. But let me tell you, I haven't come across any 2 people, forget about 2 families, who are alike, who think alike, who react alike. So that only when, as a doctor, as an oncologist, you don't talk so much to the patients, but during the genetic counseling, post-test counseling session, when you spend half an hour, 45 minutes, 1 hour with the person, then you realize each person is different, and there is no Indian family. Each person is different, and in the genetic counseling process, each person has to be dealt with as an individual. So like in this family, so like this lady cannot even speak Hindi, and some of them are always on the Google and they're trying to find out. They also know what Angelina Jolie is thinking, not only what she has done. So this is a kind of spectrum of families that you will get in the country. So the lifetime risk of developing breast or ovarian cancer is quite high in those who have a mutation in the breast cancer gene. BRCA1 is the first breast cancer gene, inherited predisposition gene, which was found, 50 to 80%. For ovarian cancers, 25 to 40%. And even men who carry this mutation in these families, they also have a higher than normal lifetime risk of developing male breast cancer or prostate cancer. So this is again a myth. A lot of people feel there's a breast cancer, so it should come only from mother's side. And a lot of doctors are confused about that. I find it very strange. Say this is a autosomal, Mendelian autosomal disorder. It's not a sex-linked disorder, but maybe that's how our mind works. So in India, we have the burden of this. If we assume 5% of all breast and 10% of ovarian cancers are hereditary, which is fairly standard across the world, then we have 10,000 families per year. And if we say 4 or 5 members per family, sisters, brothers, nieces, then we have close to 50,000 individuals who are high risk of developing breast or ovarian cancer. And we fail to identify most of the high-risk families in India. At Tata Hospital, in our registry, presently breast cancer, we see every day 1 new hereditary breast ovarian cancer family. That means, but in a year we see only about 350. There should be many, many more. And so where do these families go? I really don't have an idea. They exist, but where they go, what services they avail of, I really do not know. So we suspect hereditary cancer, or one should refer them to genetics clinic if you are lucky to have one in your hospital. Obviously if there's a family history, bilateral disease, or breast plus ovarian cancer, or early onset cancer. And very important, this is a group of people who are concerned. They may not fit into any criteria, but they are concerned. I think they also merit genetic counseling. And I was surprised that a lot of people feel that breast cancer is hereditary. The fact that breast cancer may be hereditary, this is lost somewhere. And people who would have just one member in their sister or a mother had breast cancer, somehow they have convinced themselves that they would also develop breast cancer because they have heard breast cancer is hereditary. So if someone is unduly concerned, then that patient also benefits from genetic counseling. We may not do genetic testing for them, but genetic counseling and genetic testing are two distinct things, and they would benefit from them. So, so they have to be referred, but many times people don't have avenues to refer them to genetic clinic. So now we have close to 3,500 families in the last 10, 12 years. So there is a clinic which runs in the Tata Hospital, and there's a lab which is in ACTREC, and the lab was set up later in 2007. So we have all hereditary cancers. Breast cancer is the most common kind of hereditary cancers, and that partly could be a referral bias because I also treat breast cancer. But this is by and large the most common hereditary cancers, breast cancer, and of course colorectal cancer. And unfortunately, there's only one genetics clinic. So anyone with any kind of suspected inherited predisposition or concern, they are all just referred to the same genetics clinic. But in advanced centers now, there are specialized high-risk clinics for colorectal cancer separately, for pediatric cancer separately, for breast women's cancer separately. But we have to cater to all of them, and all of these have specific mutations which are present. So in our own cohort, we have in close to 3,500 women, we had about 1,000 patients who had families who had a classical hereditary breast ovarian cancers. Some of them would not fit into this classical sort of definition, but there's a familial breast cancer, or there may be early onset breast cancer, like someone developing breast cancer at the age of 29 or 32 without any family history. You always wonder as to why did they develop breast cancer. So genetic testing for HBOC, there are several issues, and this is very important. This just no way you can sort of gloss over it with the ethical, legal and social implication, and these have to be dealt with as part of the pre-test and post-test counseling. There was a time when I started all this, there was no genetics labs in the country, so we had our own academic lab, whatever little limited testing we could do. Today's scenario has changed. There are at least 8 or 10 private companies in the country which offer genetic testing, and the cost has also come down substantially. So the cost there was not available, and the cost was so high. But what has happened, the downside is a lot of women have undergone genetic testing without a proper genetic counseling or pre-test counseling, and I think that is a double-edged sword. Genetic testing should never be done. I really mean never. It should never be done without genetic counseling. I don't have time to explain to you the process of genetic counseling, but that is sacrosanct. That is an inviolable rule. So the criteria for genetic testing, there are various criteria which were ruled earlier. One was that the probability of finding a mutation is more than 10%, but this sort of threshold is becoming less and less. And we should know that what the person understands and what are the expectation, the cost and timeline, that has become less now. And what we have been doing, we have several founder mutation, recurrent mutation that we have identified in the Indian population, so we quickly check for them. And then if we do not find, then we do a full BRCA1-2, and gradually we are also moving to gene panel testing. And for oncologists, it is important to know how to interpret the genetic test report and act upon it, because many of the labs are new, or they would have a tie-up, someone does the sequencing for them, but they finally write the report. So the report is not always clinically relevant. So ultimately it's the doctor's responsibility. If you get the report, you have to see what it means. Just describing a mutation means nothing. Is this mutation pathogenic? Is this mutation a variant of unknown significance? And how to act upon it? So this is the oncologist or the surgeon's duty. So far in the databases and literature, there are only about less than 400 South Asian families with a BRCA1 or 2 mutations from anywhere. This includes Indians, Pakistanis, within the subcontinent or living in Malaysia or Singapore, anywhere. So this is a very small database, and of these 375 families, 200 plus, now we have 212 BRCA positive families, which is from our cohort. And BRCA1 is the most commonly mutated gene, followed by BRCA2. Very importantly, that many times the mutation is a hotspot mutation. That means at a specific site you see that mutation, and that can be tested quickly by genetic testing. So we could contribute to more than 50% of all the South Asian BRCA families, because ours is a comprehensive unit. The clinic and the lab both sort of are run by us together, and we have a large cohort of more than 1,000 HBOC families. Genetic testing, we were doing it free of cost as part of ICMR research funding, and we used a simple method of cost effective and rapid screening for the common mutations before we moved on to the NGS. So this chart shows that penetrance. Penetrance means if there are 100 women with a BRCA1 mutation, what proportion of them will develop cancer? If penetrance is 80%, that means 80% of them will develop breast cancer by, say, whatever age, 75 or 80. So, when this had started this, people used to say, Indians, even though they may have a BRCA1 mutation, they will not develop cancer because our diet is different, we eat curcumin, all those things. But when the mutation is in a gene like BRCA1, I think the diet or the lifestyle, if at all, has a very weak modulatory effect. It is like a very major something which has gone wrong. So they have a 75 to 80% lifetime risk of developing breast cancer, as well as 30% risk of developing ovarian cancer. And they generally develop cancer quite young. So this is one of the most common mutation that we find, 185. This is in BRCA1 gene called 185 del AG. This is also known as the Ashkenazi Jewish founder mutation. But it so happens that this is the most common mutation in Indian families also, and this has arisen independently in India. So this is a hot spot. So this segment of the gene is more prone to undergo mutation, and like it happened in the Ashkenazi Jews, it has also happened in India. So this is the families where they hail from, and this what we have done, what we call is a haplotyping to show that where they come from. So this is another mutation which we find coming mostly from the west coast of India. This is another mutation in BRCA1 gene. So what we do is the geo-ethnic frequency. So what we find is that vast majority of families belonging to same specific community had a very specific mutation in BRCA1 or BRCA2. And this is because till recently Indians did not marry outside their particular community. Mutations occur, these are random events, they are probabilistic events. So few hundred years ago, in 1% developed or had a BRCA1 or 2 mutation, and because they continue to marry within their own community, and before they died, they already had children who inherited this mutation. So we may find that specific communities have specific mutations. So we have hereditary breast ovarian cancer families from Konkanas Brahmins, CKPs, Bohras, Jains, Western Ghat origin. They have very specific mutation in BRCA1 and 2. So like we described in Ashkenazi Jewish mutation. So in India there are probably few dozen subgroups who have very specific private community specific mutations. So in families with specific geoethnic background, instead of testing for all the 84 exons of BRCA1 and 2, we test only the exons in which mutations are usually found, and this reduces the cost and the time which is required. And more importantly, our advice is also specific, because that particular mutation has been well studied and we know what is the penetrance, what are the chances of developing cancer, what are the benefit of specific preventive actions. So then we go out to the communities. So in Mumbai, all the communities of the country are represented in Mumbai. No community is not, so we go to their community and we do the population screening to find out what is the incidence or the prevalence of this specific mutation in that particular community. So now there are measures to reduce the risk of cancer, from chemo prevention, tamoxifen, to prophylactic mastectomy. This is what Ms. Jolie did. So prophylactic oophorectomy, that means ovaries are removed. And prophylactic oophorectomy, there is a high uptake even in healthy women if they undergo a detailed counseling, pre-test counseling and post-test counseling. What we find that most of the women, they understand the value in getting their ovaries removed after the age of 35 or 40, after the childbearing is complete, because that is the best way to prevent cancer. Of course, now there are targeted therapies which have come. Those who have a BRCA mutation, they can respond better to specific targeted therapies because they have this specific mutation. And those, they may develop ovarian cancer, but if they have a BRCA1 or 2 mutation, they respond better to platinum therapy. So the mutation which caused the problem for them is also now a solution. It also helps in improving their cure rates. So this is a very sad slide. Even though in our cohort, these people knew that cancer is running in their family, they were still coming late and they were dying young. So majority, half the women in these families, despite knowing it very well, they were presenting late and they were dying. So this is a big challenge for us, how to change this scenario. And genetic discrimination is another thing which happens. It is more than wrong, it is a life-threatening abuse of a potentially life-saving discovery. And genetic discrimination does happen, and this is one of the ethical, legal or social aspect of genetic testing. So these women are not deriving any benefit. As you saw that many of them are dying even though they know that they are at inherited cancer risk. On top of it, they are facing discrimination. So we have to go to the people to sensitize the people. This was an Indian Express which covered before the Angelina Jolie story. Now, in many of the South Asian countries are also in the similar status. We have made an Asian BRCA consortium, and except South Korea and Japan, all other countries are equally bad shape. So this is a snake and ladder of genetics. Genetics is, mutation are seen as the snake, but you can, with modern technology and counseling, you can make it a ladder. So we are on the 3rd floor, and as I say, every day people just walk in and our clinics are so full. There is great need for every hospital, every city to have cancer genetics clinic and genetic counselor, because these people exist, these families exist, except they don't know where to go, whom to ask for, and what service they will get. Thank you very much.
Thank you, sir. Dr. Mallika Subramaniam is the head of preventive oncology at Cancer Institute. She's a trained oncologist. She's a trained gynecologist who did her fellowship in gynec oncology at Tata Memorial Center, Mumbai. Her work primarily focuses on prevention of cervical and breast cancers and epidemiology and interventional studies of the same. Her current work involves HPV testing as a primary